Er ist mitverantwortlich für das Programm heute und ich danke ihm an dieser Stelle ganz herzlich, dass er sich dementsprechend eingesetzt hat und auch im Bereich der Moderatoren dafür gesorgt hat, dass wir das Panel so illuster zusammenstellen konnten. Thomas, bitte sehr.
Ja, vielen Dank, Tullio. Ich möchte Sie auch von meiner Seite begrüßen. Ich werde die Einleitung des nächsten Gastes auch auf Deutsch machen, weil ich weiß, dass er sehr gut Deutsch spricht. Wir freuen uns sehr, dass Chris Bangma aus Rotterdam zu uns eingeladen oder unserer Einladung gefolgt ist. Wir haben ihm einen nicht ganz einfachen Talk gegeben heute. Es geht um genetisch bedingte Tumorerkrankungen der Urologie. Und wir freuen uns sehr darauf, was wir hören können zu Erkrankungen, die uns in der nächsten Zeit wahrscheinlich immer häufiger auch von Patienten gefragt werden, was wir mit ihnen machen sollen. Vielen Dank.
Ja, vielen Dank. Es erstaunt Sie nicht, dass ich meine Präsentierung in die englische Sprache geben wird, weil ich nicht so flüssig bin in die deutsche Sprache. Aber ich hoffe, dass es genügend sein wird für dich. Und ich habe auch einige dieser Slides präpariert für Sie. Sie können diese im Internet bekommen nach dieser Präsentation. So I'm shifting to English, and I thank you very much for having approached me and for the opportunity to talk about this title, which covers more than my talk, because this is an enormous, large subject. But the aim of the talk, therefore, is to raise awareness. The second is to show you the level of the art of the game of this moment, and to raise maybe at the end a little bit of a discussion about screening, because of course the screening by all means can be improved, and the question is whether genetic factors are going to contribute to that. Good. So most of my talk is just like cancer progress. It's a miscopying of what other people have been saying or have been writing, and as I told you, you will be provided with some thoughts about it, and I would like to share you some of these points. We're most aware that there's more knowledge and facts about kidney genetic predisposition than there is in prostate, but prostate, of course, is hot, not only in the scientific community, but also amongst our patients. So that's what we are going to discuss, and some of you might have been aware of this evoking subject by means of this conference. And conference, especially consensus conferences, are very dangerous conferences because it some way suggests that the opinion of opinion leaders is the proof for guidelines or making guidelines, which of course is not. We just heard that hard rock science is the basic, is the base for all the developments for our implementation of things in our patients. And over here you see something like 98 Americans and 2 Europeans sitting in a conference in Philadelphia. And these are so many Americans, not in the first place because it was in the United States, but second of all, in the United States there is a reimbursement for genetic tests, which therefore provides a lot of new data they can discuss about. But it was timely, of course, and we were there, and I will, this article just has appeared in which you can read the consent making and also the products of it. And taking this product of that, let's say, publication at hand, we made in Rotterdam at least a design for how to handle in prostate cancer patients the genetic testing. And you can read it, of course, and it's in Dutch, so for German-based physicians it will be easy to follow, and it is only a proposition, but it gives you an idea that you can, in a certain setting, start up with exploring the genetic value in patients who want to know about their genetic background. Good. This looks like a physics paper from CERN, more than any urology paper. And I'd say this is the way to go in this most complex field in which many urologic but also non-urologic contributors can do something about studying. And this is a European study that tries to highlight the importance of the presence of the BRCA1 and 2 gene, that is the breast cancer gene. And this breast cancer gene, which we know of course, in female with breast cancer, as a hereditary factor, is also important for example, prostate cancer. And this consortium finds out how much. And they made this publication, in which we will discuss later on. But this is the second one, also published last year, and it shows that by combining even more knowledgeable people and data from around the world in the practical consortium, that all of these genetic data come together with many very tiny factors that might contribute to, in part, to the existence or the promotion of, in this case, prostate cancer. So it means that the genetic factor, wherever it is and how well studied already so far, is only in part, let's say, responsible, for, as far as we know, for the startup and the promotion of prostate cancer. That is what at stake. What is it, the question that we are asking ourselves? And that is, of course, is a genetic factor contributing early on in an asymptomatic stage to diagnosis? What does it mean for our patient? Is he better off by having this genetic diagnostic or genetic role in the promotion of his tumor, and can be treated therefore more successfully if we detect it early on? And then, of course, in the background of this, do we harm which we should not, and what methodology we should use? Now, something basic about predisposition. Each of you carries aberrant genes, genes that are mutated a little bit. There are small mistakes in it, copying mistakes from our body. And it means that you're not going to have a disease, but you are a carrier. And you might carry that on to the next generation, or that might not be the case. Often we need several of those mistakes in order to trigger a disease. And these mistakes on a gene are not always located on one place, but it can be somewhere around the line of a 20,000 nucleotide gene, and it might vary very much. Most of these that become visible to us are autosomal dominant. So that means that on two alleles you only need one mistake in order to get it, the presence, the physical presence of a cancer or a disease. And it means that there's a large variation in what we see, as well as in expression, as well as in intensity. And we talk about expression of a mistake of a gene, and of the penetrance of it, when over lifetime this alteration becomes visible. So more or less, we have to say this is a mistake in the DNA, and it becomes visible in 85 years' time of life. So we have to wait till the patient has died, almost, or gets to that age, in order to be certain that the genetic mistake is going to visualize and going to be important for his life, or her life. And then, again, it is the level of expressivity which also changes, of course, the appearance of what we see and what the patients experience. So what this slide says, there's a lot of variation. A mistake does not always lead to a disease. In population screening, of course, we have to have a very sensitive tool. We have to pick up everything, like in PSA with a low value, we pick up every prostate cancer. But then, of course, you have a high diagnostic specificity test, which is a biopsy. That is in screening. And of course, it's obvious that the screening test for genetic alterations is one of high sensitivity, but it is not diagnostic. It's not diagnostic of having a tumor. We need something else for that. So it only prepares for finding a cancer. But it has certain other effects, like psychological effects. Knowing you are a carrier gives, of course, effects. And of course, there's large cost effectiveness involved in this. How much does this kind of screening cost? So altogether, we can say in favor there might be an early treatment. There might be a change in the, let's say, the behavior of the patient. He might alter his life. Even the society might alter his life by, for example, taking away smoking, cigarettes, risks. There might be a relief after testing, but on the backside is the anxiety, a lifelong anxiety of a diagnosis, having an alteration in your genes. And of course, as always, just like this imaging, as we heard, the danger of overdiagnosis and overtreatment, doing something for nothing, without a reason, or enough reason, without enough effect, is around the corner. Good. Still, we are being asked, and we are being asked increasingly so, because the awareness of the public about genetic screening and also the confidence in the effectiveness of screening programs, because we lower the incidence of disease, not only of tumors or prostate cancer, but also of other diseases by genetic data. This confidence is high, so we are being asked, maybe not today, maybe tomorrow, but I have several patients and you have several patients that have been asking about genetic screening. So we have to do with this something today or tomorrow. At the same time, and therefore this talk is also very timely, we as urologists, as a profession, are very reluctant in offering testing. It's laborious, it's unexplainable, etc., etc. So we are rather conservative in offering this in our systems, and therefore we know little about it. And as I told you, there's variation in systems which provokes data. Actually, when you have an aberration, a simple aberration in a tumor, it's very easily and cost-effective being screened, because it's not that difficult. It doesn't need a lot of money in order to find one specific alteration in your genome. It's just taking a little bit of blood, taking the right tracer and the right imaging tracer, connected to it, and you have your diagnosis. And this is for a few, maybe less than €100 available for specific alterations. If you would bring this to the level of population screening, then it needs enormous complex logistics. Not only because it needs an education of the population how to deal with risk. Is it the same as crossing the street or buying the wrong car or whatever? Can you compare risks in your how to behave with it? But it also needs, as I told you, lifelong commitment of getting data in. And also, because it's the genetic changes might only explain 30% of the occurrence of cancer, we also have to register all kinds of other things. What do they eat? Do they smoke? What is their physical activity, etc., etc. So there are many confounders, which brings, therefore, genetic screening far off, because it needs an enormous registry and an enormous analysis. But on the other side, there are data opportunities. And that data always, for you and for me and for scientists, is of importance, because we can take bloods and we can take maybe whole genomic screening, whatever, and it brings us about maybe the far known, unknown gene for this or that disease. Maybe by expanding the genetic analysis, we will see and understand more of certain diseases. And that is attractive because it triggers our curiosity. And it's feasible also because the prices of these whole genome tests are coming down rapidly, and at this moment they are around €2,000, maybe even less per patient. So it's going to be feasible. That is only the test. The analysis of it might cost the same. So it's not cheap at this moment, but it is feasible. We're doing, of course, already a lot of genetic testing. And in our field of urologists, the red starred items are of interest. There might be diagnostic testing, confirmation of a certain disease. And we are talking about pre-symptomatic and predictive testing. Do you have something in your family? And therefore, do you have to test it yourself? Do you bring it to your children? Carrier testing. And of course, new in the box is the susceptibility for certain drugs. If you have an altered gene, you do not get, for example, chemotherapy or certain forms of chemotherapy because they will harm you, they will bring toxicity and no effect. And we're getting into this area very rapidly. Good, so altogether, there must be suspicion in order to test. There must be a good quality test, must be reliable, and most important, it should help the patient at somewhere. And that is the indication for thinking about genetic testing. Good. Few things about kidney cancer, and it's rapidly because this is textbook knowledge, but it is up to the level as we know it. Approximately 10% of the cancers of the kidney cancers do have an inheritable effect. So it means that it is reasonable to test these as long as we are aware of other symptoms, because these kidney cancer aberrations come in syndromes that are important for our patients. These are aberrations that we find in the whole complex syndrome of the disease. And the key hints for this is the kidney cancer starts early, on an early age. It's multifocal. And the other thing which is important, if you recognize it, don't handle it yourself. Refer it to genetic counseling, because I have highlighted already that the psychological, let's say, discussion and bringing over this information, the discussion about carriership and getting children, yes or no, the discussion about susceptibility and risks is so difficult that we do not have time, we do not have the experience, we do not have the education for doing this. So make yourself somewhere a border and do not cross that line. If you are going for genetic testing, find your best friends in order to do so, and that's only in a, let's say, limited setting. Good, so if affected in kidney cancer, of course treat it, and there are guidelines about it, that most of the inheritable kidney cancers are not treated until they reach the level of 3 centimeters. And if somebody is at risk because there is something in the family or something like a phenotype that leads to the suspicion of having a kidney cancer, then of course screen. What do we have? We have a very sensitive genetic testing actually for most of the syndromes in which kidney cancers play a role. And actually we have already so much information about VHL syndromes that there are treatment protocols and guidelines all over the place. So we don't go to discuss that in detail, but I'll only mention that. And this is one of those that can be downloaded, but it simply says if you have a certain histology, for example, a clear cell carcinoma, and you have the extra clinical features, like mentioned over there, glioblastoma, for example, then you have to refer to a genetic counselor. And this is actually the sequence that you have to take into mind. And if you are handling kidney cancers, papillary cancers or clear cell carcinoma, just put it somewhere in your app or whatever in order to refer to it, because it is far too complex to take as a basic, easily rememberable tool. The Van Hippel-Lindau disease we know by extrarenal features in the retina, the cerebellum, and the kidney, angioblastomas that lead to all kinds of symptomatic disease, and we know it's autosomal dominant, so you inherit it from your father or from your mother. We know where it's located, so we can make a very good test for it. And these are the clinical features that you have to be aware of, and this is student knowledge. Easily put into a graph that can be put on your phone, and please remember that is always a case for epididymectomy when there is not a very aggressive, but a growing tumor at the site of epididymis. So please, when finding or when having this syndrome, check your patient for his scrotal content. There's another less frequent disease, bird hog dupe. As always, it has been invented at several places in this world, and there's also named as such, also autosomal dominant inheritance. You can find it in 25% in this symptomatic patients. You find renal tumors. So if you have a follicular aberration, folliculitis, intense follicular disease, the dermatologist should think of referring towards the urologist for screening of the kidney. Another, let's say, dermal aberrancy you can see over here, multiple haematomas all over the body, in all organs. Most of them, of course, benign. In Cowden's disease, not very frequent, but if it's there and it's very recognizable, of course, then you have to look for a P10 mutation, also easily testable, and that indicates an aberrant pathway that is associated with the occurrence of cancer, also of the treatment of cancer. So you find cancers also in the kidney that are aggressive and malignant in these cases. You have to check for that. Lymatosis and renal cell cancer is connected to papillary disease. Tuberous sclerosis, everybody knows about it, connected to angiomyolipomas and other aberrancies all over the body. Clear cell carcinoma, and as I told you, these testing panels are widely available. They are in your laboratory, they are commercial, and they're good, high sensitivity, high precision, and they are reasonably cheap, so to say. And these test large panels of genes, up to 80 genes in total. So you can imagine that this is a thing that will discover a lot of actual mutations in genes. So shifting to prostate, I have to be rapid, I see, and that is about familial or hereditary disease. What is familial? What is hereditary? There are some definitions about it, and it's better to use them. And we are talking in publications about hereditary disease when the occurrence of the cancer in the family is more strict. It's in 3 generations, or it's in 2 very close relatives, brothers, brother, father, and at the early age. And before that, we're talking about familial. And this is just in order to stratify our knowledge and to go on with it. But it also stratifies our risk. But because in hereditary disease, the chance of getting a prostate cancer is 4 times higher. As you can see, the odds ratio 4.39 when compared to the average population. So it is relevant to indicate the familial composition. And there's been a lot of work having been done on this. We have been recognizing that prostate cancers are in certain syndromes. They are connected, associated with breast cancer or ovarian cancer in the family. The underlying genes have been identified. And although these genes have not always been validated, the HOXB13 gene has been a candidate for hereditary disease. It's connected to polyposis colon, so the malignancies that come up with colon screening nowadays, and which we are being confronted by our colleagues from MDL. This patient has many polyps. Does he have prostate cancer? It has been connected, as I told you, also already with the breast cancer gene, and in that connection, and as a result of the study, the European study that has been shown up front, we can even see that the risk goes up 7-fold. Then it really becomes something relevant to think about and to consider screening. It is not the only DNA repair gene we have. There are certain others, certain other mutations that also give an extra risk, although not as high as BRCA2. And therefore, the conclusion nowadays is, yes, there is a genetic factor. Yes, it is very likely to be connected to BRCA2. Yes, we find in metastatic disease, very often, up to 12-20%, a germline aberration. And this germline aberration is going to your sons and daughters. Lynch syndrome, polyposis coli, also endometriosis, endometric carcinoma, just be aware of it. And this is also the relevance for the patient, not only for their offspring, but also for now, because there's increasing evidence that PARP inhibitors that correct for this mechanism of, let's say, controlling the DNA replication, that these PARP inhibitors are going to play a role somewhere in the treatment of metastatic prostate cancer. So overall, with this knowledge, and the increasing knowledge there is, you can say, well, we've done a lot of work. We have been doing even complete genomic screening in certain patients, but of course in target groups. But altogether, we can say the implications for screening and treatment at this moment are unclear. Well, that is a bottom line message, isn't it? Still, in the United States, you might be confronted with a guideline already. We do not have that in Europe or anywhere else. And that is about, let's say, the indications for BRCA2 testing. And these BRCA2 testing, they advocate for doing in an early prostate cancer at the age less than 50, and with family members, more than 2 normally spoken, also with breast and ovarian cancer, and to go further, therefore, with the testing of your potential patients. This is very targeted testing. This is not testing overall, not taking many diseases, certainly also not kidney disease or other inheritable diseases. It is simply focused BRCA2 testing. It's very easy, can be done very quick, and it's only, of course, a predisposition gene. They've been making a workup for this in MSKCC, and like that we have been making up something in Rotterdam. And if you go to that and find it closely, we have made it, let's say, easy in order to have the pre-screen of our patients that are coming with the question, do I have a prostate cancer because it's in my family, to give a questionnaire to the oncologic nurse that supports the proper evaluation of the family. Ovarian cancer, which age, breast cancer, which age, etc., etc. So it doesn't take you too much time in your office. But it might, by means of a point system, refer to a decision for reference to a clinical workup, a clinical genetic workup. So if you want to use something, do it in structural way, because this is the only way in order to get the data of how often do we have BRCA2 carriers in our population, because we do not know. And it is also the only clue of getting long-term data, and maybe in 20, 30 years' time, is it useful to put this into a population genetic screening. And so far, we can, till that time, we can only go in incidental screening in families that we feel that are at risk, and the risk can be objectivated by means of a questionnaire and a point system. Good, this is actually the same conclusion from the Philadelphia. Just shortly, the last 2 slides, consider this. The patient autonomy. The patient, if the patient doesn't ask for it, there's no reason to offer for it. But if the patient asks for genetic screening, you have to consider and to know what to do. The privacy about this genetic data, of course, is very much, let's say, disputed and cannot be protected in the systems we have. And patients may ask about it. So be aware of the safety of the data, because there's nothing more sensitive than a PSA and a genetic screen, of which they are afraid that it will roll over to somebody else, to another scientist, etc. So I advise you, if you go into genetic screening and support, always have the patient sign a consent. The patients can deal dramatically different with information on carriership. And so be aware of that, because you are getting those patients back from the genetic physicist. And you have to be aware of it. And you started it. The most important thing, of course, do no harm. And in screening, that is subject of an intense discussion, has always been. Minimize that harm for yourself, for your patients. Try to reduce anxiety, because it is a promoting factor, it's not a diagnostic factor. And at the same time, we have interest in promoting data from cohorts. if you want to get those data, take a consent, but all of us are longing to get the importance, the data about the importance of genetic testing. So take off, we have a fast development of tests, whole genomic testing. You cannot avoid it anymore to keep away from it. There's little awareness amongst urologists in general about it, what to do. There's always a lot of doubt. But the patient autonomy forces you at least to refer to somebody who knows. And there is variable availability for the prostate cancer test at the moment. The BRCA2 test is very good, but all the other genes, like the HOXP13, etc., don't go into it because there has no consensus about which test to be used. For renal cancer, of course, that is completely different. Those tests are very good. And be aware of the awareness and anxiety of your patients. There's emerging guidelines for BRCA2 testing, so we have to keep up with this talk, and they are established for renal cancer. And it might not only affect the offspring, but it might affect the patients very soon with drugs that are entering our practices. Most of all, whenever you start with it, consider together with your patient what is the value for your patients of knowing to be a carrier. And I'm happy to leave it at this point.
Thank you very much, Chris. Are there any questions from the audience? Herr Moch?
Thank you very much for this nice overview. I think we have nowadays two clinical scenarios where we are confronted with genetic testing. One is in renal cancer, that we see more and more SDHB deficient renal cancers and HLRCC associated renal cancers, and by the way also MSI unstable tumors and urothelial cancers of the pelvis, where we have to do genetic testing without a clinical geneticist. The other scenario is prostate cancer, where we do genetic testing for other tumors, and we identify by accident the BRCA mutations, and this is more and more frequent. So what is your recommendation when to involve the clinical geneticist? Because you said we should early inform the patient that we do this, but just to do the correct diagnosis, we have to do the genetic testing.
Yeah. I don't think that I have a straight answer for you. And it is something that is in discussion within your hospital or your region, how to confront patients with information that they have not asked for. That is one bullet point, I think. And this will vary over let's say, the health systems in Europe or in the United States. So that is difficult. The only thing I can say is when you go about your responsibility of having identified an unknown BRCA mutation, and you're going to tell that with your patients, when you are unexperienced, do it with somebody who is experienced in this game, and therefore take your friend, the genetic physicist, into it and say, this is how we are going to handle this information to this patient. That is my current advice. Does that address your question?
Are there other questions? I have a practical question for the kidney cancer patients. Do you generally recommend that every patient you diagnose with a kidney cancer that and he's younger than 40 years old, that he should be informed about the possibility to get genetic testing?
I showed you the slide that the kidney cancer combined with the indication of a certain kind of a physical, let's say, explanation result is an indication for testing. And you can do that along a scheme. In that is also an arrow that says that if there's a kidney cancer diagnosed below the age of 40, there is an indication for genetic testing. So it is in the American guidelines to do so.
Yeah. And one more question from a clinical point of view. If you identify a patient who is a carrier of, let's say, a BRCA mutation, is there any data that shows that these patients, for example, should not undergo active surveillance for prostate cancer?
I'm very careful about it. Indeed, the paper about the BRCA mutation showed that a patient with a mutation are diagnosed at an earlier age, and they are diagnosed with more aggressive disease. But as upfront, the paper is about patients that already have been diagnosed with BRCA2, and we are not known with the patients being carrier, but not included in this cohort. It's very difficult to really validate that endpoint, whether these patients are more aggressive. So what I do in my practice, I indeed mention this paper to the patients with the BRCA2 mutation, and I tell them these are the results. I have doubt about the results because they are not easily being validated. But what I do is I take, let's say, the conservative scheme for surveillance, whether this is a patient up front before having a diagnosis of cancer or on active surveillance, and taking not the fire off shoot by saying, for example, well, I can't see anything on your MRI, just come back in 5 years' time. So I'm more careful, let's say, about screening, but the optimality about, let's say, the interval timing, nobody knows.
Okay, thank you. Girish?
That was a wonderful overview. From a societal perspective, this is taking off in Canada and North America, and patients are worried about insurers for life insurance getting this information. And so there are laws in my country that protect the patients. Are there similar measures in the European Union?
Officially, I think in the national states there are. European Union, of course, is an interesting collaboration in which many things are being collaborated, especially, but with the acceptation of, I have to say, except for healthcare. National societies are very proud of their own systems and therefore have their own rules, and these rules are not uniform around Europe. So yes, there are societies, health societies, in which data are very well protected, and also where it is indicated in which way it has to be done. And that these data cannot be used for example, insurance, buying a house or whatever, financial, let's say, or commercial enterprises. So yes, protection should be, and I think your responsibility, if this protection is not there by law, has to be taken by yourself and say, what am I doing? Where do I share these data? Where are they going to land? How are they going to be protected in my own institution?
Okay, thank you very much, Chris. You are very lucky that you are in the session that I moderate, because you will get some chocolate from Switzerland.
Well, Swiss, there's nothing beyond Swiss chocolate. Thank you very much.